Welcome everybody to our PEDS Learning Community First Depression webinar. This is Lydia Franco, part of your resource team, and with me presenting today is also Dr. Anthony Salerno. Originally, Anil Chaco was listed as the presenter, but unfortunately he's sick today, so we will be filling in for him. So a brief review, and actually just before I get started, a little bit of an orientation. We're going to be talking a little bit and reviewing about depression among children. We're going to be talking a little bit about MAP and that MAP process that you learned in our in-person meeting. We're going to discuss some depression-specific measures that you can use with children. We're going to talk a little bit about using your dashboard with your first client. Some child-specific indicators that you may want to keep in mind. And we're going to go over a couple of the most common practice elements, in particular psychoeducation, cognitive restructuring, and monitoring. And then we're going to discuss the session planner briefly in terms of helping you prepare for your next session with your clients, some next steps, and ideally we're going to have the last 5 to 10 minutes for Q&A. Currently, if you have not used the phone line system, we won't be able to unmute you if you raise your hand. So I think what we'll be doing is if you have any questions, just use the chat box on the bottom right in your panel. You would type in the chat box and then send to all panelists. Make sure you click all panelists and then send for us to be able to see your question. And also, if you're having any technical difficulties, make sure to send that to the host, and she'll be able to address any of your technical difficulties at this time. So currently, everybody will be muted, and you'll be listening to the presenters. So we first wanted to start off with a quick check-in, and this is a polling question that's just going to pop up on your right-hand side. And the question is, have you had the chance to choose a child with a primary diagnosis of depression to focus on in this first quarter? Do you have a client in mind already to get started with the MAP system? Just click yes, no, or if you don't know, that's fine. You can click that as well. And we'll give it a couple of seconds, and then we'll see what the results are. Okay. Evelyn, when it looks like we have enough, we can show the results. Takes a couple seconds. Okay, there's a little bit of a delay, I think, when we click over to results. Okay, so it looks like about half of you have identified a client, only a couple of you haven't, and we didn't get a chance to hear from some of you. So it sounds like everybody's headed in the right direction in terms of identifying a primary case with depression. So again, just if ideally you are identifying somebody from your caseload or somebody who's a new intake, either one is fine, whoever you think would be a good match for using the MAP system. So thank you for answering that poll, and we're going to have a couple of those throughout. So first, before we get started on the MAP system and the common elements for depression, we wanted to give you a little bit of background on depression, so and sort of how the prevalence of it in current society. So essentially, among children in the U.S., we find that about 1 in 40 children are affected by depression, and that the risk factor for having depression, it also gets worse by age, where by adolescence, by the age of 18, we see about 1 in 10 adolescents exhibiting some type of depressive disorder. We also see some gender differences, where girls are more likely than boys to experience depression. And that we also know that depression is also not just a mental health issue, but also is connected to physical health, and that oftentimes it is connected to major causes of disability, both starting in adolescence all the way through to adulthood. So it's an important context to consider the prevalence of depression at this point in society and amongst children. So we're going to check in with you with a separate polling question on how many children have a primary diagnosis of depression on your specific caseload. So hearing those numbers, it would be helpful for us to know how many do you carry on your caseload, and I know that your caseloads will vary greatly as well. So if you have about 1 to 2, or 2 to 4, 4 to 6, or more than 6 children with a primary focus of depression, just let us know. We'll take a few seconds to let you answer, and then we'll show the results. Okay, I think we're pulling up the results. Okay. Sometimes it takes a little longer than others. Here we go. So actually we see kind of across the board, right? So a couple, it's really split up. A couple have just 1 or 2. Some have 2 to 4. Some of you have more than 6. So that's also important to know that for some of you it's just a couple of your cases. For some of you it's a lot of your cases. So thank you for giving us a little bit of perspective on how many cases you actually carry specific to depression. So in thinking about depression among children, there's a couple of things we also want you to think about, and that's really sort of the family context, right? So oftentimes we find that if there's a family history of depression, that the children are more likely to be at risk for developing depression themselves, especially if the primary caregiver is suffering from depression. We find that compared to children whose parents don't have depression, children who are being taken care of by a parent with depression oftentimes will show the symptoms earlier in life than children who don't have parents with depression. So that's an important challenge, and we know from talking with many of you, some of your cases also have caregivers with significant mental health issues. So that's important balance to consider, and what that role of the family history plays in the child's development as well as progress. We also know that the structure of the family and the family dynamics, whether there's there's a lot of conflict in the family, or if it's chaotic, if there's substance use issues both within the family, or if the children and teens themselves are having substance use issues, we know that all of those are risk factors for depression. So it may be also important to take into account a little bit of that family history and thinking about how best to address some of those issues in your treatment with your case. So some things, just a review really around depressive symptoms and indicators for kids who have depression. And I think this varies by case, really. You won't see the same sort of combination of symptoms. And I think it also varies by age or developmental stage, and I think it also varies by gender. So sometimes you'll see irritability or anger being exhibited. Sometimes it's a lot of sadness or hopelessness, withdrawal, both from family as well as friends, or participation in activities, is sensitivity to rejection, or you can sometimes see that in school, you know, really being sensitive to maybe comments from teachers or other friends or peers. And then the appetite and sleeplessness, issues with that, whether they can be increased or decreased appetite, or too much sleeping or too little sleeping, can vary depending on the child as well. Excessive crying or outbursts, sometimes difficulty concentrating, which can be a challenge if you also think the child may have ADHD or some other issue, or anxiety, because you can see that there as well. Low energy or fatigue, which may coincide with decreased interest in activities and the sleep issues. A lot of physical complaints like stomach aches, headaches, pain, that may not respond to treatment. So if they're seeing their pediatrician and there isn't really any resolve of the issues, then we start to wonder if it's more of a mental health issue as opposed to physical health issue. Difficulty functioning during events and activities at home. So things that they used to do really well. Maybe they're in sports, maybe they're in other types of activities, and now they're kind of struggling with it. feelings of worthlessness or guilt, and thoughts of death or suicidal ideation, especially in the older adolescent group, is particularly problematic. So we want to give you an opportunity to use the chat box and give us a feel for what are some of the depressive symptoms that you find, and which ones do you think is most challenging. So if you go back, if you use the chat box, and again, that's that bottom right in your panel, you can type in the chat and then send to all panelists. And let us know if there's any indicators or symptoms that maybe we missed that you tend to see often, and which ones do you find to be most challenging. So just take a few seconds to type in that box and then make sure to send to all panelists. Okay, so we have Melissa saying sometimes poor sleep is an issue she sees a lot. Somatic complaints again, which, yeah, very common. Any other ones? Okay. Okay, and then we also have inattention, anger, and irritability. And some of those are also, I'm sure, some of the most difficult ones to manage. Self-harm, and that's an important one. I think we heard that a lot in our in-person training, is concerns around cutting or self-mutilation and the challenges with that, especially as they get older. Any other ones coming in? Okay. And I just wanted to open it up again. So any specific challenge. So with the cutting or with the anger, or the irritability, somebody just wrote in a risky behavior. What do you find to be most challenging with those issues? If you can type in like a brief response. And we also got suicidal ideation and irritability. Use of drugs or alcohol to cope with depression. I mean, I think what I'm seeing is also the complexity of the issues, right? So it isn't just like one or two indicators. Sometimes you have quite a number of different symptoms or indicators. Some are more challenging to deal with, like maybe the cutting and the drugs and the alcohol. And it also seems like then trying to tease out the comorbidities of some of these things too. Managing the risk or risk management. Funny, two people submitted the same thing at the same time. So the liability, the concerns there, the self-harm issues, I mean, those are important matters that we have to take into account, especially as the children get older and they're more likely to take more risks and be more impulsive. And somebody just wrote in lack of family support, and that was going to be my next piece, is this idea of, you know, with these complex this many number of risk factors and the difficulty in managing them, this lack of family support is also a huge issue, right? So if as a therapist you also had the family there kind of providing, everyone's working together to surround the child with a lot of support, then things would probably go a little smoother. But when you don't have that family support, it makes things much more complicated. So ideally, we're going to keep talking today about the role of the family and the caregiver and thinking about some of those common practice elements. And we're going to talk a little bit about how to talk to the family, how to incorporate them in that process, and how that may vary by developmental stage. So thank you, everybody, for
Lydia, I'd just like to add something, if that's okay.
Go ahead, son.
Tony Salerno. First of all, welcome everyone. I'm so pleased we have a good number of folks who are on, and we appreciate your involvement. You know, as I was just reading down the list of these challenges, what impresses me, of course, is that treating depression is no easy thing, and not only that, it's a scary thing because people are clearly identifying issues around safety, around risk, around self-harm. You know, all of these are really serious issues, and I think one of the hope we have is in making some informed decisions about the kinds of strategies that you can employ to address some of these very challenging issues is really the whole point of the PEDS project, is to enable you to develop a whole menu of potential strategies to address some of these really challenging issues. So it's just very clear that we clearly are hitting on a topic that's very important. You know, we'll have also a second webinar on the area of depression, again, so that we can provide as much information and to see to what degree the MAP system can help you and the child and caregivers to develop some specific strategies to address some of these really high-risk concerns that folks articulated. So I just think that's a very important point to make. Okay, I'll turn it back over to you, Lydia.
Thank you, Tony. That was a great point, and I think it also helps introduce this next piece about looking at the different presentations of depression by developmental stage, and I think some of you can also add more to this. And if somebody wrote in also that depression doesn't necessarily look like what they show on TV. So I'm not crying all day long, so I'm not depressed, and I think that's an important point, and also is important to take into account when you're talking about children and their developmental stage. So sometimes when you have young children, you're talking about, you know, the 5, 6, 7, 8-year-olds who may not be so verbal, who may not be very self-aware or able to identify their feelings very well. What you see is more of somatic complaints, like the stomach aches, the headaches, the pain, some of the irritability. You may see this kind of crying and they don't know why, or sadness, maybe a little bit of withdrawal there too, and not wanting to maybe go to school. And so you see more of the irritability too in older youth, more withdrawal than normal for young children, loss of interest in activities and not wanting to hang out more. Maybe you see more of the sleeping in, the truancy or not wanting to go to school is huge. The school refusal is particularly huge for older kids. And this idea of irritable mood, that it isn't the crying all the time. It could be anger. It could be oppositional behavior. More of the externalizing as they're trying to help, as they're trying to make sense of their feelings and emotions. It's sometimes easier for children to exhibit it more physically and in how they relate to people than to kind of totally withdraw and spend their time crying in the room, although you see that as well. So I think it's important, and I think that's an important point in psychoeducation, which we're going to talk about later, is in normalizing some of this, some of these feelings and these concerns that they have, and helping the parents also to understand this variability. Because I could see parents saying, well, they aren't crying all the time, they're acting out, so they're just behaving bad, when in reality is really more of a mood issue. And how can we inform and set that stage for support through psychoeducation as we move through the treatment process. Thank you, everybody, for responding. We're going to move now that we kind of set the context for depression among children. We wanted to start looking at the MAP system, and we're just going to do a very brief review of what you learned in the in-person training that you all attended in the last couple weeks. So as you know, and hopefully everybody's had a chance to get on the PracticeWise website and really peruse through the different tools and databases and the guides as you start getting familiar with it and preparing to use it with your client. The first is that PWEB database. It's that online database. Then there's those practitioner guides, the dashboards, and we also have those additional resources and worksheets that we used in the training. So if you remember this handy-dandy quick start slide from our training, and here it describes it as steps, as 1, 2, 3, 4, 5 steps. But I do want to make a point that it isn't so linear, and you may have to go back and forth through these steps. But in terms of a case with depression, when you do that initial PWEB search, this is essentially what you're going to get. It may vary slightly depending on the age ranges that you pick or some of the filters that you use, but this is really what you're most likely going to see. And that cognitive restructuring specific to depression is a very common practice element. Then you have psychoeducation with the child. I think the word child is cut off there a little bit. Activity scheduling, having them participate in more activities, maintenance or relapse prevention, problem solving, monitoring, and on and on and on, right? So that you'll see a number of practice elements that have more frequency in use in evidence-based practices and in studies specific to depression than others, but that you really have a choice here of picking from this list to meet the needs of your client the way that you think makes the most sense. Then we also had talked about the treatment planner, and that this is really a worksheet that you had gotten in your folders, and that is also on that PracticeWise website under the PEDS Learning Community project page, project section. And this is that worksheet where it helps you conceptualize the case. And thinking about, especially for this first quarter, this case of depression, what are those practice elements? Going through that list and figuring out what is the treatment process really going to look like for my client in the beginning, in the middle of treatment, and the end of treatment. And here we have just an example, but it doesn't have to be these specific practice elements. Ideally, this is your opportunity to really adapt that evidence base to the needs of your client. Then there was the dashboard, so it's kind of small here, but you can see that on top we're tracking the outcomes, we're tracking progress using the standardized scale specific to depression. We're also tracking another type of more easier to track outcome like bouts of crying or participation in activity. And that bottom half with the dots and the lines is really where you track which practice element were you able to use on which appointment day and whether they missed appointments and things like that. So you could really tailor it to make it as useful as possible to you and your supervisor. So again, the top is the progress, the bottom is the practice. And then there's those practice guides that you can access through the PracticeWise website again. And those are really the how-to guides for doing those common elements, those practice elements that come up. And they're really sort of the step-by-step guide. Sometimes you can adapt them to make them more of a checklist, whatever makes the most sense for you. But important to kind of review and go over as you prepare for your session. So really looking at that session planner worksheet as well and thinking about preparing before the session, thinking about what do you think makes the most sense for your client, reviewing the dashboard, really preparing for that session by going over those practice guides. Then you have during the session where you're really thinking about either an opening, working, or closing, or a beginning, middle, and end of the session. And how best to structure that session and make sure that you're getting enough feedback from the child as well as the caregiver if they're part of treatment, working actively on some of those common elements, and then kind of wrapping up the session and reviewing and maybe assigning homework. So many of you may also be assigning homework or tasks that you hope that they'll do in between sessions. And then after session, really kind of processing how much of the guides were you able to accomplish, going to the dashboard and tracking some of those assessments, and then preparing for the next session or checking with your supervisor. And I think what's important here is for some of you, you may be doing this all concurrently, especially if you're doing that concurrent documentation. So some of the after work you may be doing during the session, like you could go over the dashboard with your client. You could write your note or use it to assess the progress of your practice, use of the practice guides with your client as well. So it may look a little different for each of you depending on your clinic. Okay, so we're going to go a little bit deeper into essentially the dashboard and then the tracking piece, the assessment and progress monitoring. So if all of you remember, in your folders at the in-person training, there was a sheet, there was a handout that had a list of standardized scales for each child diagnosis. And we also highlighted for you the one specific to depression. And there were quite a few on that list, but only a couple of them are freely and openly available to the public. And here are 3 good ones. I'm not sure actually if the RCAS we gave to you, but I know in the folders we gave you the CES-D for the child and the PHQ-9, which is really better for adolescents. The RCAS, if it wasn't in your folder, all 3 of these are going to be available on the PEDS project section under the PracticeWise website. So you'll have links directly to those, and you can download and use those. However, I think it's also important to note that many of you may already be using standardized scales in your clinics. You're welcome to use those. You don't have to use these. We just wanted to make sure you had some available to you if you wanted to use them. Some of you are also using, for example, like the CBCL. So CBCL does have a depression subscale then you can also just use that subscale to track for the purposes of this learning community. So you don't have to institute a new assessment if you don't want to. So I just wanted to go in, give you a little bit more of an overview about two of them, the CES-D child. It's used for youth ages 6 to 17. That's primarily a child self-report. So the child is really giving you a feedback on how well they're doing. The RCADS is for about the same age range, but the difference there is that you can get a parent report or the child self-report. So you may want to think about what makes the most sense, and do you want parent as well as child report. The PH29, you had the handout that we gave you had some good instruction on how best to use those, and that is particularly helpful for adolescents, but also a self-report. So we just wanted to give you a brief example as you're getting ready to develop your own dashboard for your client. So here's one example of this will be like a 12-year-old child who we're tracking with the CES-D depression scale, and we're going to use it every 4 weeks. And I think we do recommend, because we're only focusing on a child with depression for this first 3 months, and then in September we're going to switch to anxiety, that for the purposes of this learning community, we do suggest that you use the standardized scale monthly so that we can try to track some progress. We wouldn't use it weekly because we don't think it's helpful and it may become cumbersome, but monthly may be a little bit easier, and that way you can kind of see that progress, any progress in those 3 months. Then we also highly, highly recommend something that you can track weekly, which is more of a personalized measure, something that's easier, maybe something that is specifically something that the child or the caregiver wants to see improvement in. And these are kind of easier ones that you can kind of count. So here, for example, we have a case where we wanted to see more engagement, so the child participating in dinner with the family and not getting up and leaving. Maybe that's more for, like a 12-year-old or preteen or older. Sleeping through the night, like how often are they sleeping through the night without waking up? How often are they getting to school on time? Any reduction in crying spells? How many crying spells did they have that day or that week? You may want to think about giving them a little worksheet to keep track of depending on what specific measure you want them to do. So at the, when they wake up in the morning, they can track if they slept well or not. Time spent with friends, how many times, for example, did you go out with your friends this week? And and you can go either positive or negative here with some of those measures. But if you want to see sort of a more positive improvement, you could flip how many nights did you sleep, or you can say how many nights didn't you sleep. But it may be more helpful to be more strength-based and focus on how many nights they did sleep. So here I'm showing you an example of this case. And this, if you remember from our in-person training, there's this Excel spreadsheet that is the dashboard. And one of the sheets is where you type in which scale you're using, whether it's on the right or the left side, the date of the appointment, and the score. So in this case, this is a CES-D. The child was assessed for 3 months, once a month, April 10th, May 10th, June 10th. We also track nights slept through. So the first appointment, they only slept 2 nights. Well, I guess, like about a week later, 2 nights, then progressively got a little bit better, 3 nights, and then 4 nights out of the 7. And the third measure is days spent with friends or outings with friends. And it went from 1 outing that week to 3 outings that last week. So if you see on the dashboard, and this is, sorry, I apologize, it's a little bit fuzzy, couldn't get it a little clearer for these slides. What you see here is on the left side is tracking using that standardized CES-D child scale. On the right side, you're doing that frequency count on nights that they slept and days spent with friends, right? So what we see here is the CES-D scale. They started at 50, and then the bottom that says 0 to 70, those are days from first appointment. So the first appointment is they're a score of 50, and then about 30 days later, because we're checking in monthly, they're a little bit lower, around 47, and then 60 days later, 2 months later, they're about 40. And then if you look at, let's just pick one, let's say days spent with friends, you're basing it on the right side. At the first appointment, if you look at the green dot and follow the line all the way to the right, they had 1 day spent with friends. And then about a month later, they had 3 days, and then they stayed about 3 days, 60 days later. So just a reminder that this is also a helpful tool that you can use with your client to visually show progress, and you can also use it in supervision to help you discuss the case with your supervisor. Okay, so I'm going to jump to our another polling question about the dashboard, and just wanted to ask if you've identified at all which measures you'll be using on the dashboard with this first client specific to depression. So we're going to show that poll now, and if you can let us know if you've identified the measure, if you haven't or you're not sure, and I would include in there if you're not sure and you need some guidance as well. So we'll take a few seconds here. Please check off if you've identified the measure, if you have not, or if you feel like you need more guidance or aren't sure. Okay, let's see the results. And what we find is about a quarter of you have identified what measure, a quarter of you haven't, and about half about half didn't answer. So there weren't any that weren't sure and needed some additional guidance at this point. So I'm glad that you're already thinking about which measure. We do recommend kind of taking a look at the ones, go to the PracticeWise website, go to the PEDS project section. The ones we've mentioned are linked there. Kind of take a look at them, figure out which one you think makes the most sense for your clients. And I do suggest identifying that one now so you can start setting up your dashboard in preparation for working with your client. But feel free to reach out to us if you're not sure about which measure to use, or if you have any questions around using the dashboard at this point. Okay. So we've given a little background on depression. We have did a quick review of the MAP process, or what you learned in the in-person training. And now we want to talk about how to actually present this to your client, and then also what are some of those practice elements that are going to be particularly important for you to think about in working with your child case with depression. So I think one important first step is thinking about engagement as you start using this system with your family. And this may look a little different for some of you. Some of you, I know, had identified that you're going to have brand new clients that are new to the clinic, you're just coming off of eval or intake, and that'll be a different kind of engagement process where you're really engaging them to everything, the clinic, to treatment, to you as a therapist. Some of you, I know, have identified cases that you've been seeing for quite some time, or were already being seen in your clinic maybe by somebody else. So the engagement process may look a little differently there. You may want to review what services are like, or what kind of orient them to you as a therapist if you feel that's necessary. But that one may be more about just introducing this new technique, a new way of something new you're asking them to try, and introducing them to the new assessments and measures if you haven't been using it with them before. And I think it's an important process to think about both in addressing this issue with the caregiver and the child, because you may want the caregiver to fill out some of those assessments, not just the child as well. So it's a discussion that may need to happen with both the caregiver and the child. And what's particularly important in this process is also then creating that buy-in or that agreement from the family, from both the caregiver and the child, ideally, in terms of wanting to give this a shot, that this is something that may be helpful, that has a good amount of evidence and support behind it, and that's something you think that may be helpful for this family. So ideally, you're getting some of that agreement from the beginning with them as you get started. The other piece is, how do we go about doing that? And this is a question we get quite often in a lot of our work with clinics and in our own experience, is how do you really create that partnership with the caregiver? That sometimes it's a little bit easier to get the child in or to work with the child, but the caregiver brings a whole other level of complexity to the services. And part of that we have found is that there's a collaborative tone, this sort of we, this us, this team kind of tone, ideally is set from the beginning as much as possible with the caregiver in particular, in terms of we need to work together, or how can we work together to address the needs of your child, that you're both looking for their best interests, but that as a clinician, I really can't do this on my own, that I really need your help, and you're an important person in this child's life. So let's figure out the best way to do this together. But part of that is also getting the parent's perspective, and as well as the child's perspective. That's important as well, but really getting and trying to understand where the parent is coming from and what are those goals. In our in-person training, we kept mentioning, well, you know, it's all, you know, that the parent may be bringing the child in for treatment because they're getting too many calls from school and it's beginning to affect their work, or they're getting called out for at work because of too many phone calls, or too many issues at school, or they're missing too many days of work and they're more concerned about losing their employment, which is an important issue as well. And so how do we attend to that? And one way to attend to that, as well as to create some of that buy-in with the family, with the caregiver, is maybe incorporate that as one of the main goals. So all of this is really about identifying what the parent's goals and perspectives are, what the child's goals and perspectives are, and working together to really set that collaborative partnership in moving forward with treatment. As part of this, it's all, again, it's orientation to the clinic, to you as a therapist, to how you work, the services that you're going to be providing, what will each session look like, what is that beginning, middle, and end going to look like for each of the sessions, what are some examples of the things that you'll be doing, and whether or not you're going to ask them to do some things at home, any of that homework, which is a tricky thing. And we may have to think about how best to present that, because oftentimes that is a bit of a challenge for families to do at home. And discussing caregiver involvement. What is your expectation of the caregiver? Are they going to be involved in every session, just some of the sessions? Are they going to have their own sessions? Really attending to some of those questions and concerns from the very beginning. Okay. So now we're going to spend the rest of the time talking about those specific primary practice elements that we know are important to cover when you're working with a child with depression. I'm going to pass it now to Dr. Salerno, who will take over this piece for now.
Great. Thank you so much, Lydia. You know, as you were going through it, I was just struck by, and maybe others were as well, is that there's so many decision points from everywhere, from the initial engagement, diagnosis, understanding the type of important symptomatology, perspective of the caregiver, perspective of the child, decisions about how we're going to monitor this progress. There are so many decisions that go into this, and all of you out there know that. This whole approach to PEDS is about decision support, is that how do we go about making some of those decisions? And then if we do decide to do a particular intervention, to ensure that we're able to deliver it in a way, you know, that's going to work. So all of this has to do with decision support. The practice elements is really part of that, and that's what I'm going to, you know, focus on really for the next 15 minutes or so. Okay, so let me see. I have control of the slides. Okay, there you go. So we wanted to focus on the first webinar on 3 of the most common practice elements for depression. So if you were to take endless hours to go through all of the research out there to ask yourself, well, what kinds of interventions and approaches are being employed in research that's associated with positive outcomes, these would be 3 of the most common. There are others that we'll actually begin to address in webinar 2. but psychoeducation, which is, how do you just impart information to both the child and to the caregiver in a way that, one, they understand what you're talking about, two, they can use that information to make better decisions and to participate in treatment, to actually try some things new during the week. So it really is around how to impart information in a way that motivates and informs and engages both the child and the caregiver. Cognitive restructuring, we'll go into a little more detail on that. I'm sure you've heard a lot about the use of cognitive behavioral sort of approaches around depression. So we're going to just focus on that and how the MAP system and the decision support and the practice-wise approach can be a help to you as you begin to think about this area of cognitive approaches. And then the self-monitoring, both monitoring from outside, which in many ways is what dashboard involves. Self-monitoring is also part of the dashboard in the sense of the individual really kind of keeping track and understanding, how would I know that this treatment or going to see my very nice therapist is really working? Is it really addressing the reason why I came into treatment in the first place? So those are three areas we want to focus on. So in psychoeducation, there's a couple of very important points. I'm going to actually show you on the screen an example of, in the MAP system, the practice guides. This is how it looks, right? So hopefully you all can see that. And it doesn't put words in your mouth about what you should say, because we have to always customize our language to the person that's in front of us, right? Sometimes there are language issues, cultural issues, educational issues, literacy issues, all of that. And that's just part of our challenge, as any clinician knows, that you just don't have the same way of communicating to every single client, that we assess that client's knowledge, their use of language, some of the prevailing beliefs that they have, ways of introducing ideas that would be meaningful to the individual. So that's just part of our challenge as in terms of doing clinical work. But here is some guidance, right, around psychoeducation, around depression. So how should I talk to this mom or dad about their child's depression? What language should I use? So part of it is to discuss the purpose and the reason for these sessions and what we're going to be doing here. So just so that there's some clarity for what to be expecting. When anyone goes to any setting, a situation, that they don't know what's going to happen, that just raises anxiety and discomfort. So part of what you're trying to educate folks about is about what we're going to be doing here, what my role is as a clinician, what your role is, what the child's role is, and so that the greater clarity there is, then there isn't a lot of ambiguity, there isn't a lot of confusion, because ambiguity and confusion is a distancing experience. And it wouldn't be surprising that people miss sessions, don't show up, all these sorts of difficult engagement sorts of issues. So you want to understand from the parent's perspective, so how do you see these problems? How do you make sense of them? Well, my kid's just a lousy kid. I knew it from the very beginning. He's just encouraged. I wish he was like my older son, who really does very well. You could have that kind of spiel going on. Or that the kid is just being lazy or wanting to get away with things. Parents, all of us, we interpret behavior. Understanding how that parent is interpreting the behavior of the child is not just a nice thing to know, it's a critical thing. Because the way you interpret it affects how you feel about it, and it'll affect how you behave. So what I just want to sort of say is that, if using this practice guide, there are a number of steps to think about, and I'm sure you say, wow, a lot of this either comes to me naturally, or it just makes perfect sense, it's like common sense, or it's an area that I've, just learned and developed as a skill as a clinician. Normalizing the feelings around depression so that people are very worried of whether or not they are like the only ones. There's something very uniquely damaged about our family and about my child and about me as a parent. Trying to discuss factors contributing to depression. What is depression? The ways in which it can be manifest. Some of the behaviors that are observed that could be a sign of depression. Finding out about the child's feeling, right? And there again, you have to shape the language in a way that makes sense to a child. Discuss skills or new ways of doing things. I have sort of like a very simple approach to that I've been using for a very long time. Whenever I'm thinking about these issues of skill or of change, one, to think about what is it that the family is doing that they ought to keep doing, that the kid is doing that he or she ought to keep doing. In other words, that's the strength of the family, that's the strength of the child, strength of the caregiver. What do they need to keep doing? And it's very important to keep one's eyes and ears open for the opportunity to reinforce what the parent or the child, the family is doing that they ought to keep doing. Then there's the, what do we need to stop doing? The kinds of behaviors, the kinds of parenting that may actually be getting in the way. And that's really like breaking a habit that could have been formed. The other part is, what do you need to start doing? And that's where you're learning some new approaches. So that's one way one can think about almost the entire change process or improvement process, what to keep, what to stop, and what to start. Okay, I'm going to go on to the next slide from here. Okay. So here are some other points. And a point you do want to make is that moods often impact the way we think, but also the way we think often impacts the way we feel and how it's connected to behavior. And that then ties things also to some of the cognitive approaches. Okay, let me go on to the next. So in the child psychoeducation, which I could also bring up, here's another example. Again, it's another practice guide. It, again, gives you some ideas of what you're trying to accomplish with this type of intervention. What are some of the steps that you can use? And much of that parallels some of the same things you would say to the caregiver. But you want the child and the caregiver to leave saying, okay, I have a pretty good idea what this treatment is supposed to be about. Gee, I even have some ideas of how we're going to know whether or not it helped at all. And I have a better idea of what the plan might be, and also that I'm really listened to when I bring up some of these issues, and that the child is listened to. So those are important things. Again, just something that is part of the MAP system. Some of these may already be things you're absolutely doing, but it may be useful to have something that you could refer to very quickly as a reminder so that you're ensured that you kind of cover the steps, right, the number of steps here, so that your imparting of information can be as effective as possible. Okay, let me just go on to the next piece. The caregiver, again, we went through some of these. Here are just a listing of the steps. Many of you just need to, okay, let me just take a quick look at the steps. All right, and I can have them actually literally in front of me. No one's going to stop you from making a copy and having it in front of you. And there's certainly nothing wrong with having guidance in front of you as you conduct, a session. In fact, I don't think we have enough tools in the work that we do because it's get to be so complicated, so many different issues, that having some of these quick cheat sheets, if you want to call it that, can be, again, very useful. So that's the issue around imparting information so that folks come out of there feeling confident that we can do something about this problem. And that's probably the most important thing, because once a family caregiver leaves this type of session, the child, they go back home, and another family member asks, so what went on over there? What did they tell you? What's that whole thing of going to see that shrink over there or whatever? What that caregiver says is incredibly important, because that's the message that they took. So part of I just want to say as part of psychoeducation, is check the understanding that the child has and the caregiver does. I would say that's an area that I wish I had done a lot more of in my clinical work, is to do more check steps. Because I would discover at another point that the person completely misunderstood what I meant, had the absolute opposite idea of what I meant, or got little bits and pieces of it. So checking understanding, I think I would add that as a very, very important component. Now, around the cognitive piece, we're not going to teach you cognitive therapy in the next 5 minutes. But again, having some guides that you can refer to around these approach, which cognitive approach is increasingly considered to be sort of a core skill and a core clinical intervention pretty much across every kind of like health problem, mental health and physical health and substance use. So understanding how people think and how that affects their feelings and how that affects behavior is not sort of a side issue. It's really like a core of understanding human behavior and the change process. So you may have already seen this very, very brief kind of model of the relationship really between thinking, feeling, and behavior. So if you were to go to one of the guides around the cognitive, what would that mean around depression? Well, it would mean conveying this idea. Not everyone naturally believes that there's a connection between thinking, feeling, and behavior. You would say, well, that doesn't sound right. Doesn't everyone kind of see that connection? The reality is not everybody sees that connection at all. And so, especially for children, adolescents, some caregivers, part of it is just increasing their awareness that the way in which a person is making sense of the world, how they interpret their behavior, the meaning of their behavior has so much to do with the way they feel and the way that they act. And particularly those negative self-thinking, negative self-talk can be incredibly damaging. And if a person doesn't alter a way of thinking that they're really stuck and really negative, that is going to be very difficult for an individual to get motivated to actually engage in change behavior. It's very, very difficult. So looking at maladaptive thinking, self-defeating thinking isn't a nice thing. It really is a core of doing good clinical work. So you'd want to identify the kind of errors, the types of mistakes that folks make in the way they think about things. And you know about like self-blaming or overgeneralizing or, you know, jumping to conclusions. All these sorts of ways in which we kind of come to understand something, and if we understand it in a way that's not really logical, that is overblown, overgeneralized, we can really begin to behave and feel in ways that are not helpful. So some of the strategies, of course, is, well, how do we challenge that? How do we begin to think in a way that's more realistic, that's also associated with more positive mood, positive aspects of situations? One big mistake is the person literally sees everything in a negative way. Part of the concept with depression is that's what happens, is you begin to, out of all the things that you can observe in a field, what you focus on is all the negative stuff. And if that person continues to think in that way, we're not going to make very much progress in terms of addressing the depression. So, okay, so, you know, I can certainly bring that up again here as an example, right, the cognitive approaches. Again, it's simply a quick guide for you to take a look at, remind yourself of some of these issues that I'm sure many of you, if not all of you, have been trained in some way. But there's so much stuff coming at you. There's so many different skill areas. Having a really quick, easy, accessible guide, we think could be really you know, a very positive resource. But you guys will let us know that as you participate in this learning community. Okay, let me go back.
Tony, I just wanted to step in a minute there, is that that is also as important to think about when you're working with a child client, how some of this will look like depending on the developmental stage of the child, right? So some maybe with older children, they may be able to tell you what those thoughts and those feelings are, maybe a little bit easier to work with them, like adolescents. Then younger children may not be so verbal, may not be so self-aware. So thinking about utilizing the monitoring, thinking about helping to identify through the behavior, what are those thoughts? Talking with the parent or if you can with the teacher around what is it that they see happening. So if they're not getting along with their peers, what happens that then that they see happening? Why does the child retreat or not from their peers? What do they think is going on there? And trying really to get at some of those underlying cognitions that is getting in the way of the improvement in mood and behavior, so that it just may look a little differently in how you approach it depending on the stage of the child.
Great. Thank you, Lydia. That's a very important point. Okay, so I just know we have just a few more minutes. And then, of course, the issue of monitoring and self-monitoring. You know, like what is it that we're looking to change? Sometimes it might be useful to use a sort of a, you know, some of folks have probably seen like the fear thermometer. There's also a depression meter. It's just a way to get someone to think about, you know, where am I right now? How sad do I feel? You know, how low or down do I feel? Like in this past week, if I had to put a number to it from like 1 to 10, and then we would check in like every week and say, how would you describe your mood in the past week? There's just a way of monitoring. It's important, you know, as part of the change process is to really enhance a person's examining their own behavior. So not only are you looking at crying spells or looking at some of these individualized indicators of depression, but that both caregiver and the extent to which the child can developmentally is also taking a look at it. So self-monitoring is sort of a core aspect of an improvement process for all of us, really. And then being able to, assign some, practice some assignments, to try to do something, even a very, very tiny step differently, which I think is also one of the pieces to a lot of these really evidence-based approaches, is that the session doesn't just end, you know, right then and there, that you leave each session with even the tiniest step that both the caregiver and the child can take during the week. And how do you establish that action step? It makes sense to the caregiver, to the child. It makes sense in light of what they're trying to improve, and that they can set a time, place, and activity related to that action step, but in a way that if they don't do it, they're not going to feel so embarrassed they don't show up the next time. So that's a very important piece. So you're also monitoring the kinds of things that the child or the parent can do that they're likely to do, that they feel comfortable doing, and will move the process along and help to improve some of the mood situation and the activity level of the child. So self-ratings of sadness, as I mentioned, caregiver monitoring, sort of these very important key indicators. And a lot of it will come down to explaining to caregivers the meaning of some of the behaviors that may not be viewed as a sign of depression. And reframing that can make all the difference in the world. And then having the caregiver really looking for some of those indicators and to monitor that over time. Okay, here's just an example of a mood meter. And for young kids, this might really make a lot of sense. So we kind of like ask them everywhere from really, really feeling sad, grouchy, not sure, I need some love, doing all right, to really the best day ever. And again, that could be something to heighten awareness both of the child and the caregiver. The session planner is, preparing for how to use the system. You've seen this before. I'm just going to kind of bring it up here. All it really comes down to is, and many of you are running from session to session to session. For the purpose of this project, we would like you very much for that one client that you're working with for this quarter, to consider the use of a session planner, the treatment outline guide, those kinds of things for at least one of your clients, and for this quarter, a client in which depression is an important clinical problem. Okay, I think we're out of time, so I'm just very appreciative of everyone's efforts. We had a lot to share with you, so we didn't get to a Q&A, but you can certainly send any of the questions to us. And I think we also have some next steps here. So on Thursday, on Monday, this Monday from 12 to 1, there are going to be some office hours. This means it's an open hours. Please feel free to call in. How do folks get the, I don't know if Evelyn or Lydia, how do folks get the call-in numbers?
So we will be sending out all that information again from Ashley.
Okay, so you guys will be
everyone will get a reminder sent today as to where to call in.
Great, great. So if there are any questions that have been remaining from this webinar or around the whole MAP approach and this whole project, we'll be sending you out call-in information. We have office hours, but if you can't make it during the office hours, just drop us a line. And Ashley, I think, is one of our main contacts. Bring up a question. She'll direct it to anyone who might be able to help you out. So let me just end on thanking all of you for being part of this. We're very, very pleased that you've joined this effort. You'll be, I think that the children and the parents that you're going to be serving and using this approach with, I think you ought to share it with them, because they ought to be very appreciative that you're taking some extra time and effort to really improve the quality of the services and to ensure that you're able to really provide, through having your decision support and other tools, that you're able to really assist in the best way that you possibly can. And I think kids and families ought to be very appreciative. We're very appreciative that you guys have joined this effort, and you're going to help us to learn a great deal. So I'm looking forward to hearing from you guys, and then we'll have a group check-in call on the 20th. Our next depression webinar will be on the 8th. I'm looking forward to talking to you guys at that time as well, and then on July 29th. So on that note, I'm just going to wish you all well.
Tony, hold on one second. I just want to remind everybody that this webinar is being recorded and will be posted on the PEDS resource page. You can find a link to either from the CTEC website, the email that was sent to you from Ashley, or through practicewise.com. Once you log in, you'll see our project page. So make sure webinars are there, as well as the resources. And somebody asked about the mood meter. We're going to see if we can have that posted there as well. And Tony, if you can go to the last slide, those are all our emails. So just feel free to reach out to us if you need anything at any point, and we'll talk to everybody on Monday as well if you have questions. So thank you, everybody. Have a great day and a great weekend.
Take care, everyone. Bye-bye.